Yesterday we have studied about CRAO and now we will be studying about CRVO. So CRVO is basically how you want to differentiate it. There is 100-day glaucoma and there is splashed tomato appearance. Like on the retina, if you see, there would be a lot of hemorrhages, giving appearance of splashed tomato appearance. Okay. And then we have Eales disease. Eales disease may there would be a lot of retinal hemorrhages, but how you will differentiate it from CRVO that there will be a TB history, and it would be a sudden onset of hemorrhage. Okay, and there will be a lot of floaters. Okay, so that is how you differentiate CRVO from Eales disease. The important is that there would be history of TB. Then let's go to infective endocarditis. In infective endocarditis, do you know there are three features that we remember as rogue, right? So we have rod spots, osler spots, and Janeway lesions. The rod spots are the emboli that we see on the fundus. So rod spots are specific to retina. Osler spots, I've already told you in CVS that osler means ouch. These are painful and these are inflammatory, whereas Janeway lesions are vascular lesions and they are not painful. Now the next part, specific appearance of C-fan appearance on the fundus on retina you're gonna see in sickle cell anemia. Also remember that SC trait is more specific for giving C-fan appearance and SC trait of sickle cell anemia, that is the mixed trait when you have a sickle cell also and C group also. When both of them are there, then you should also consider the possibility of having medullary cell cancer, medullary cell subtype of RCC. Okay, now let's go to torch infections. As I told you that cornea infections are usually from outside infectious agents, whereas retina infections are basically from torch infections, which happens because of in the development, like in the in utero infections, which happen to the mother. Torch infections are basically the cause for retinal infections. The first most common cause is CMV. CMV belongs to beta viridae. Okay, you have to remember the family. This was an INI question. So we have CMV. It has pizza pie appearance of retina, and the treatment is Jancyclovir. And in HIV, the risk of CMV increases when the CD4 count is less than 50. Toxoplasma, there is headlight appearance or macular scar appearance, headlight and fog appearance or macular scar. Or if they give you a punched out lesion appearance, think in the terms of toxoplasma. For syphilis and rubella, on the first page, I have already told you how to differentiate. Like syphilis would be three. Don't speak bad, don't listen bad, don't like I have told you all that. So in syphilis and in rubella, both of them you're going to see salt and pepper retinopathy. How you're going to differentiate is that in rubella you're going to see pearl-shaped cataract, and in syphilis you're going to see your interstitial keratitis that I have already told you. Then in sarcoid, you're gonna see candle wax dropping appearance. Okay, so this is about the infections. Now, I have already told you that there are two sorts of diseases of there could be diseases of rods also, there could be diseases of cones also. So drusen, which is basically ARMD, could be wet or dry. If it is dry, the treatment is antioxidants. Basically, there is no fluid deposition there in the first layer of retina. And if it is wet, then there is fluid deposition, and for treatment, you're gonna give votepotin and photodynamic laser. For best disease, which is the disease of the cones, the investigation of choice is EOG because it is the disease of the cones. So, which we have three waves in the electroretinograph. We have A, B, C. Already told you, but this is more specific for rods. So, in retinitis pigmentosa, you're gonna think of ERG, but when you have cones disease, cones involvement, think of EOG. Okay, so in best disease, EOG uh, is the investigation of choice. Also, the Arnold's ratio reduces. Okay, it has egg yolk sort of an appearance, and it is basically because of dystrophy of the cones. There's another thing which is called as Coats disease. It's a very specific question in marrow GTs. But Coats disease is telangiectasia plus egg yolk appearance. So you're going to differentiate between Best disease and Coats disease. Then, this ma'am has not told you Coats disease, but it is a good idea. If you give ortho test any of these mini tests and all that, you'd be there. It is a very frequent question of Maro. Okay, now rods. Rods, I have already told you that retinitis pigmentosa, right? It is involvement of the 3q chromosome. The docosahexaenoic acid is reduced. That results in BAW. So BAW, you have to always think of BAW when you think of retinitis pigmentosa. Bony specules, arterial attenuation, and waxy pale disc, right? And so docosahexaenoic acid is less, so the investigation of choice being ERG. The first wave, which is the layer of the A wave, would be less. Okay, so this is on chromosome number 3q. In 3p, there is Wall-Hippel-Lindau, right? And also remember that docosahexaenoic acid is a type of omega-3 fatty acid. This has been a question of biochem. Okay, now let's go to Cohen's disease. One another atrophy of the cones called as Stargardt disease. So what happens in Stargardt disease? There is an ABCA4 gene mutation, and it is called as silent choroid disease because EOG is absolutely normal. It gives you a copper beaten skin appearance because of the thin blood vessels over here. Right? Also remember, always remember three types of things. When there is retinal detachment, they're gonna give you curtain falling appearance. When there is Eales disease, they're gonna give you an appearance of vitreous hemorrhages. Okay, and when there is CRVO, they would be giving you an appearance of the splashed tomatoes. Okay, then there is another disease called as congenital stationary night blindness, which is called as Ovochi disease or which has the Mizou Nakamura phenomena. What happens? What is this phenomena? On light, when you put on light, you see the yellow spot, and on dark adaptation, that spot is absent. So this is called as congenital stationary night blindness, and this is called as Mizou Nakamura phenomena. Very characteristic. You can see the Google images also, and ma'am has told you this also, right? That on light the yellow spot is present, and as you go in the dark, that spot fades away, right? So this is ABCA4, which is Stargardt's. I have written all these ABCs which you can confuse, in the topics. So. Um, ABCG2, which is CD34, you see in pterygium. ABCA4 you see in Stargardt's, and ABCA1 you see in Tangiers, in which you have to correlate with the levels of HDL. Right? Now let's go to retinal detachment. As I told you in yesterday's class, retinal detachment, what happens is basically the first layer separates from the rest of the ninth layers. Okay, and then retinal detachment has a classical keyword that you're going to look for, that is curtain falling appearance, which is called as Shopper signs. It could be of three types: tractional, serous, or rhegmatogenous. Traction means something is pulling it off. Something is pulling the retina off. So basically it happens due to the virtue of blood vessels which pushes the pulls the retina. See this? There's some sort of fluid which is, hampering the retina, stretching the retina. So for this, USG B type scan is the investigation of choice. And rhegmatogenous, there is high myopia. So there is just tearing it off. It goes off its tensile strength. And what you're gonna give for treatment is silicone. There's an appearance of silicone oil or inverse hypopyon when you inject SF6, right? Uh, for the retina to swell up, right? And you can also do scleral buckling. Now, let's go to retinoblastoma. So, retinoblastoma is associated with chromosome number 13. It is autosomal dominant. It is associated with white reflex, and white reflex is due to the calcification which is present in the retina. Okay, that gives you a white reflex. It can also be associated with persistent hyaline vessels, right? PHPV. And very important, you have to go look for Flexner right rosettes. Okay, so are they true rosettes or are they false rosettes? That you will tell me all the type of rosettes and where they are seen. Okay, it is sporadic in 60% of cases, and 40% cases it is hereditary, out of which 33% is non-familial and 70% is familial. It is autosomal dominant, it is associated with chromosome number 13, and if it is trilateral retinoblastoma, pineal gland is also involved. Most common association of RB gene is with osteosarcoma. Okay, and This is just a correlation when we will at last, when we will study all the chromosomes, we will study that Wilms and Ewings go together. Okay, and retinoblastoma and osteosarcoma go together. Okay, so the most common route of spread is direct spread more than spread from optic nerve, and therefore contrast enhanced MRI is a very important, a good investigation of choice. Also remember, enucleation is done, and the treatment that we used is VECR regimen, which is vincristine, etoposide, and carboplatin. So this I've also, just a mnemonic that walled prolapse and trocele is type 1 of D. Lacey classification, type 2 is cystocele and rectocele, and type 3 is erythrocele. The treatment for bilateral retinoblastoma is neoadjuvant chemotherapy followed by surgery. First, you have to reduce the size of the tumor and then you have to do the surgery. Now, the most important thing that many of you fumble in, it is uveitis. And I have asked this question a lot of times. Uveitis could be anterior, it could be middle, or it could be posterior. Anterior uveitis involves the iris plus pars plicata, right? Middle uveitis involves the pars plana, which has the characteristic snow banking appearance, which we have already studied yesterday. And the posterior choroid, there is no wall in vitreous, which results in floaters appearance. So all of three of them have different appearances. Anterior one has keratic precipitates, and the treatment that you want to give because pars plicata is involved is steroids plus cycloplegics. For middle one, which is pars plana involvement in which there is no banking, you have to give steroids. And for the posterior one, you have there is no role of cycloplegics again. There is just role of steroids. There are floaters in that. So there are keratic precipitates, and also remember that the in pupil there are copy spots. Copies basically is a characteristic feature uh, in pupil that what do you see in festooned pupil that when you give a mydriatic agent, when you dilate the pupil, you find that adhesions and that results in festooned pupil. So always remember festooned pupil is not a thing that you will see um, everywhere. It is only when you give us a eye dilator and then you are be able to see festooned pupil. There would be keratic precipitates in the aqueous chamber. There would be Kopi's pupil, there would be Busaka's nodule. Kopi's would be seen in pupil and Busaka's are seen in the stroma. And festooned pupil is because of the iris synecdoche formation, which you're gonna see on giving uh, an adrenergic agent to the eye. Okay, now types of keratic precipitates. How I remember this was MGPS. So mutton ball, you're gonna see granulomatous conditions. Granular, you're gonna see in rheumatological conditions. Pigmented is in juvenile idiopathic arthritis. Already told you that RA results in scleritis, whereas JIA is the version of arthritis which results in uveitis. And stellate always asked you this in rheumatoid also HSV toxoplasma VKH. Now there are sorts of panuveitis. Panuveitis you're gonna see in VKH and Fuchs heterochromia iridis. In VKH, what happens is there is how I remembered this was that there would be eyelash color change. Hertoge sign also, do you remember that there would be eyelash loss in thyroid? We have studied that. Then there will be Swigura sign. What happens is sunset glow fundus. Morning glory fundus happens in another disease, you will tell me, but Swigura sign is sunset glory fundus. Right? And sunset sign you have also studied in hydrocephalus. So just a correlation. And Fuchs heterochromia iridis, there is iris color loss, there is posterior subcapsular cataract, and then there is Amsler sign, not Amsler grit test. Amsler grit we have studied in macula. The specific Amsler sign which is because of hemorrhage in the anterior chamber. So if I was an examiner, I would definitely ask you what is Amsler sign. Okay. Then conjunctiva, this is something that I'm gonna teach you in person in the live class. So do remember till here, till uveitis. I have already told you here. Okay. So this is both of these phenomena results in panuveitis. That means anterior, middle, and posterior. All of the three segments of the iris is involved.